All right. Well, good afternoon, everybody, and thank you for joining us today. This is Matthew Rubin with the CPOP team. Really pleased to have everybody on the line, all 75 plus of you, and continuing to grow. Once again, thank you for joining the CPOP MAPTA webinar series focused on the confluence of the opioid epidemic and the COVID-19 pandemic. We're really pleased to see such a robust turnout for this important dialogue this afternoon. Over the next 60 minutes, we're really going to focus on how advances in digital health and telemedicine have developed in this context over the last several months as we've entered public health emergency and national emergency. For additional information on the entire series, please do visit www.cpoponline.org for more information, or you can also reach out to myself. A few housekeeping items at the outset. For the best viewing experience, we recommend closing any programs or browser sessions running in the background. Since webinars are bandwidth intensive, closing any unnecessary browser tabs will certainly help conserve that bandwidth. If you're experiencing any technical difficulties, please visit the webcast help guide by clicking the question mark icon near the bottom of your screen, or reference the technical tips. These resources cover common questions that might arise at any point during the next 60 minutes. The webinar console you're looking at can be completely customized. You can minimize, resize, or move any of the open windows. At the bottom of the console are multiple application icons. If you have a question during the webinar, you can click the little Q&A icon at the bottom of the screen to submit your questions to the presenters. We'll try to answer these during the webcast, but if we run out of time, your question can certainly be addressed via email and follow up. I now want to call attention to the resource list located on the left-hand side of your screen. There you can download a copy of presentation slides and access additional resources. We're pleased to be joined today by two leaders representing CPOP and MAPTA who will help guide our discussion. To begin today's program, we're pleased to be joined by CPOP co-convener and MAPTA chairwoman, Congresswoman Mary Bono. National leader on confronting prescription drug abuse. Congresswoman Bono has helped lead CPOP since October of 2014. With that, I'm really pleased to turn it over.
Thank you, Matt, and thanks to all of you who are on the line today. I was just commenting that I think I've finally mastered Zoom, and now I've got a brand new technology thrown on me, but hopefully it'll be glitch-free for all of us. But we have a tremendous group of speakers today on this key topic. And as you may know, this is the first in a series of 4 webinars diving deep into the impacts and ongoing policy initiatives related to the confluence of the opioid epidemic and the global COVID-19 pandemic. Many of those responses have hit at the core of longstanding CPOP and MAPTA priorities. So CPOP and MAPTA are partnering on this webinar series to further dialogue around preventing opioid abuse and overdose. According to recent data highlighted in the Washington Post earlier this month, opioid-related overdose deaths have skyrocketed since the beginning of the pandemic. This comes on top of new data just released by the CDC showing that overdose rates increased in 2019 over the one-year decline that occurred in 2018 that many of us have been working so hard on over the years. So that's bad news. But that pre-pandemic data is only further compounded by additional federal data just released, highlighting the rise in overdose deaths during the first quarter of 2020. CPOP, which is the Collaborative for Effective Prescription Opioid Policies, was formed more than 5 years ago to develop, disseminate, and advocate for balanced solutions to this crisis. With more than 80 participating organizations from all sectors, CPOP remains focused on this mission. And Mothers Against Prescription Drug Abuse is a growing grassroots movement among families who have resolved to turn their experiences into positive change with loved ones across society. It was founded by a group of mothers who each lost a child to an overdose, and we've been together now since 2011. So together, CPOP and MAPTA bring enormous reach and expertise to these challenges. So it's now my pleasure to introduce today's webinar moderator, Mr. Rich Hamburg, who is the Executive Director of the Safe States Alliance. Rich joined Safe States in 2018, where he serves the nation's state leaders in injury prevention. He previously served as Executive Vice President and Chief Operating Officer at Trust for America's Health, or TIFA. where among his many other public health initiatives, he and his TIFA colleagues helped form CPOP together with me, my colleagues Matt Rubin and actually Matt, you weren't there yet, but Dave Zook, and also CADCA. So at this point in time, I'm pleased to turn the webinar over to Rich to introduce our first speaker of the webinar. Rich?
Thanks a lot. Thanks a lot, Mary. So we're pleased to have join us from the Centers for Medicare and Medicaid Services Center for Consumer Information and Insurance Oversight, Director Randy Pate. Randy serves as CMS Deputy Administrator and the Director of the Center. In his role, he leads CMS's work on the individual and small group markets, including the health insurance exchanges. Director Pate holds bachelor and law degrees from the University of Alabama and received his master's in public health from the Johns Hopkins University Bloomberg School of Public Health. So today we're pleased to hear from Randy regarding a recent bulletin issued by CMS and the Substance Abuse and Mental Health Services Administration, SAMHSA, focused on leveraging existing health and disease management programs to address substance use and mental health during COVID-19. So with that brief introduction, we're pleased to turn the webinar over to Director Pate. The floor is all yours.
Thank you, Rich, very much. I appreciate that introduction. Also, I'd like to thank Congresswoman Bono for you all inviting me to join you all today. The Congresswoman, it's been a number of years now, but I have fond memories of working with you and your team back when you were on the Hill, when I was a professional staff member on the House Energy and Commerce Committee. So I won't talk about how many years ago that was, but it's great to be on the phone with you all and great to be talking to you. So as everyone knows, the COVID-19 pandemic, has really taken a devastating toll on Americans and many aspects of American life. But even while we battled, the pandemic at CMS, we really have continued to press forward on all of our critical issues that we were working on before the pandemic, including the public health crisis of opioid misuse and overdose. And we certainly do recognize the importance of viewing the effects of both of these health crises together and rather than viewing them in silos. So under the National Public Health Emergency declared by the President back on March 13th of this year, we were empowered to take a number of unprecedented, but I think very necessary and sensible steps to waive certain Medicare, Medicaid, and Children's Health Insurance Program, or CHIP, requirements. And these requirements were mostly under the Social Security Act, specifically under Section 1135 of that act. CMS has taken, I think, full advantage of this flexibility to expand access to telehealth services. In this case, we are really allowing them to be used as a substitute for services that are usually provided in a practitioner's office or in a facility, whether it's to Medicare beneficiaries, including for those, with substance abuse disorders. So specifically during this public health emergency, we have extended flexibilities for Medicare beneficiaries receiving services through an opioid treatment program and allow them to obtain counseling, therapy, and in some cases the periodic assessments, over the telephone without having to leave home and without having to, risk unnecessary exposure to the virus. And for Medicaid beneficiaries, CMS issued guidance to states outlining their options for using telehealth to expand access in rural areas and to provide substance abuse disorder treatment to Medicaid beneficiaries more broadly. So especially during the COVID pandemic, we've encouraged really all states to make full use of these tools to help their populations overcome the challenges involved in accessing care during this time. So within the center I direct within CMS, we focus on the individual and small group health insurance markets, as Rich just said. We recently released a bulletin targeted for health insurance issuers, highlighting what we see as potential opportunities to leverage existing health and disease management programs to provide both mental health and SUD resources during the pandemic. during the public health emergency. And so I'd like to take the rest of my brief time with you today to really talk through this guidance. So in issuing the guidance, we were really excited to partner with our colleagues at SAMHSA. And I think we wound up with hopefully an informative document that will have a positive impact. And it was great to work with them collaboratively. So this guidance takes an approach similar to what we in SOCIO have done previously with issuers on the opioid epidemic. So we think it's really important to share best practices and ideas across the health insurance industry for combating both epidemics, both the COVID-19 pandemic and the opioid epidemic. So we've held facilitated discussions with health insurers to try to gather best practices and help share those across the industry on management of the opioid epidemic. And so this guidance that we issued really takes a similar approach by putting out some of these best practices and, specifically relating them to the epidemic about how insurance carriers can leverage the existing tools and resources they have at their disposal to help their beneficiaries with mental health and substance abuse disorder concerns. So first and most importantly in the guidance, we remind health insurance issuers of how important it is to ensure access to mental health and substance abuse disorder resources through their products. Because substance abuse disorders can cause or exacerbate a number of physical ailments and conditions, we also noted it's important for health providers to routinely screen, treat, and support the recovery of individuals with substance use disorders. The guidance document also describes practices that issuers may wish to consider in implementing a response to COVID-19 with a particular focus on the role of telehealth. So first, to reduce the spread of COVID-19, we've encouraged issuers to expand telehealth options, including a variety of formats like online platforms, but also telephone-only services. So many health insurance issuers have already expanded their coverage during telehealth during this emergency, but that would include, it also includes treatment of mental health and substance use disorders. And so as an incentive for health care professionals, we also have encouraged insurers to make reimbursement rates for those services that are delivered by telehealth, comparable to the rates that they would pay for the in-person services. We also encourage issuers to reduce practices that they may use, such as prior authorization and other limits on telehealth services, when it comes to covered mental health and substance abuse disorder during the emergency. So while these tools can be important in managing healthcare costs, they could have the unintended impact of discouraging the use of telehealth services, at a time where it is really essential to limit the number of people who are physically present at a clinic or hospital. So, you can envision a situation where, providers are stressed already, and so, we think it's, helpful to relax some of these prior authorization requirements so that people can focus on delivering care. Continued delivery of mental health and substance use disorder services via telehealth in this environment is especially critical. So next, we encourage issuers to re-examine their provider networks to ensure participating mental health and substance abuse disorder providers can provide the services that they offer via telehealth. So SAMHSA recently released guidance related to operations during the COVID-19 public health emergency for outpatient treatment programs, OUD treatment programs, and other substance use disorder treatment settings, and has a number of other important resources in this area that we referenced in this bulletin. The next tool we discussed is online platforms. So prior to the COVID-19 public health emergency, many issuers established online health and disease management programs to encourage their enrollees to stay healthy generally. And we continue to encourage these programs, but now many issuers are using these same platforms for efforts to mitigate the stress associated with COVID-19. So some examples of that include virtual drug and alcohol recovery support services, for enrollees with mental health and substance use disorders. It also includes electronic newsletters and blogs specific to managing stress associated with COVID-19, and webinars that provide stress and anxiety management education. And so we felt it was important for issuers to know that there is a range of ways they can reach people with mental health and substance use disorders in this current situation. Peer support services are another valuable resource that is being used by health insurance issuers and that we wanted to encourage as well. So, private organizations and local governments that provide online or over-the-phone peer support can be a real stabilizing resource and an access point for a range of other critical services and supports. For example, several health insurance issuers have initiated programs to connect members to community resources, including virtual support groups. And others that we have seen out there have provided links to community, state, county, and federal resources on their public-facing issuer web pages. Health insurance issuers have also partnered with community organizations to provide no-cost counseling using a 24/7 support line that's staffed by professionally trained mental health and substance use disorder experts. And some have initiated well-being checks and using calls and email for enrollees that are at higher risk with COVID-19, such as older adults and rural or otherwise isolated individuals. So finally, in the guidance, we highlighted some of the innovative uses that we've seen out there of mobile applications. And as you all know, mobile applications really do make professional and peer support more accessible and portable. And they also really do have the potential to reach people who we may not otherwise be able to help due to transportation barriers, inability to travel, or other factors that can impede their access to care. Several insurers have launched free on-demand apps that help enrollees cope with stress, anxiety, and depression during the COVID-19 pandemic. Online resources can be incorporated to raise awareness and screen for substance use and mental health disorders, as well as resources for help. Some of these apps allow virtual face-to-face sessions or text messaging with a licensed therapist. Others allow games or offer games and activities to address issues maybe people might be facing, as well as providing reading materials, video demonstrations, and online forums. So I hope you will take a look at the bulletin that we issued, and it's really a list in there. It provides a list of many additional resources that are referenced there. So both within SCIO and across CMS as a whole, we really have been committed to continuing our work to combat the opioid crisis, even in the middle of the COVID-19 pandemic. So thank you very much again for the opportunity to speak with you today. And with that, I will turn it back over to Rich.
Thanks a lot, Director Pate. I appreciate that. Appreciate your remarks and continued efforts to help address mental health and substance use disorder issues faced by individuals nationwide, only to be further exacerbated by the current circumstances. So I'd like to move on. We have a panel. We're pleased to have a panel of 3 national leaders set to provide remarks this afternoon, focused on 3 distinct areas of clinical care related to acute and chronic pain and substance use disorders during the COVID-19 pandemic. As you'll see in the slide displayed, our next 3 speakers will bring or lead a dialogue that better outlines how clinicians and others responsible for patient care and coordination have responded to the current circumstances. Our traditional methods of care and engagement with patients, caregivers, and others has all but been upended during the COVID-19 pandemic. Over the next few minutes, we'll take a deeper dive into the policies and regulations related to prescribing and dispensing of medications and ability to facilitate a patient-provider relationship, including its impact on our long-standing effort to turn the tide on drug overdose deaths. Please note that we'll be saving all questions and answers for all of our panelists until after our presenters have provided their remarks. At any point between now and the Q&A, You can submit questions to the panelists using the Q&A function on the left-hand side of the screen. We'll do our best to get through those questions in whatever time we have remaining. In the instance that's not possible, we'll work to provide some additional follow-up. So first up, we'll hear from Dr. Jeffrey Gooden around the impacts of COVID-19 on addressing acute and chronic pain. Dr. Gooden is board certified in pain medicine, anesthesiology, addiction medicine, and hospice palliative medicine. Is a medical acupuncturist. Dr. Gooden's clinical and research focus includes novel non-opioid analgesics, post-operative pain management, opioid abuse and potential solutions, and increasing clinician awareness of pain assessment and risk management. Received his medical degree from Albany Medical College, yay, my hometown. He completed the residency in anesthesiology at Yale University School of Medicine and a postdoctoral fellowship in pain medicine, the Yale Center for Pain Management. Turn it over to you.
Hey, Rich, thanks so much, and thanks for that great introduction, and thank you all for joining us today. You know, listening to Randy Pate, it's just amazing how the regulatory or administrative climate really, you know, jives with what's going on clinically right now. I think the strategies we're taking are good ones. Unfortunately, as you heard from our previous speakers, we're kind of falling behind the eight ball when it comes to substance misuse. And you saw from the title of my, you know, brief talk here is, the overlap between chronic pain and what's happening during the recent pandemic. The other disclosure I'd like to add is that I'm a consultant to Quest Diagnostics on their drug monitoring and toxicology side. And I put that in because I want to talk a little bit about some of the data that Quest has garnered just in the last few months during the COVID crisis as compared to what drug misuse looked like pre-COVID. So just as a baseline, let's talk about what it's like to be on the front lines out there of medical care. Clinicians who treat patients with pain and also those who see patients who have substance use disorders have to recognize that during the pandemic, patients are at increased risk for misuse of prescription drugs, alcohol, and illicit drugs simply from the stress that we're feeling related to COVID. Now, this is probably worse for those with pre-existing mental health conditions, but let's face it, this stress is really impacting all of us. From knowing people who've gotten COVID to maybe seeing loved ones who've actually passed away from the disease to losing our jobs or being displaced from home and childcare. I mean, there is tremendous psychological tension surrounding this current viral pandemic. And we know from treating patients with pain for decades now what the risk factors are for misusing prescription drugs. And clearly, there are some populations that are more at risk than others. Those with pre-existing mental health conditions, those who've been on controlled substances for long periods of time, those with a history of substance use disorders, those with a family history of drug or alcohol abuse. We know there are certain risk factors, and clinicians need to be astute to these so that they can pick them up during their interview when they see patients. Now, one of the biggest troubles I see during this pandemic is that traditionally, we have lots of treatment options for patients with pain. Complementary treatments like hands-on physical therapy, acupuncture, other complementary modalities, rehabilitative modalities, interventions like nerve blocks and implanted devices and surgical procedures, and equally important things like cognitive behavioral therapies and other psychological counseling. But what I've seen so far is that in this COVID crisis, the only one of these things that has survived is pharmacological therapies. And with the current stressors of COVID, we see people increasing their activities at home, having more pain, and calling us for more medicines. And our only choices here are pharmacological treatments. And I think that's putting us a bit more at risk. Now, treating patients with pain clearly requires an individualized approach. I'm doing this 25 years, and I'll tell you that compliance is one of the biggest challenges we have in pain medicine. And I think that's because most of the medicines we use aren't that great, even the strongest of opioid pain medicines. Maybe they take pain away for a couple of hours. But when we give patients, 60 or 90 of these tablets and we tell them it has to last for 30 days, the timing, the temporal nature of the way we dose these medicines, it doesn't make sense. So people run out of their pills early. The treatment is always complex. We have people that have been in, train collisions and airplane accidents and boating injuries and car accidents, and they've had cancers and devastating surgeries. These are not simple patients that we deal with. So the pathology is quite complex, and that we know that there's significant overlap between patients who have chronic pain disorders on controlled substances and some of those patients who will misuse the medications in the long run. So we see this public health issue related to overdose death. And I think, as Randy mentioned a few moments ago, sorry, someone's changing slides here. As Randy mentioned a few moments ago, forgive me on the slide thing, we know that there are these spikes in drug overdoses. If you look at the statistics I found from the Washington Post just about 2 weeks ago, the suspected opioid-related overdoses jumped 18% in March, almost 30% in April, and 40% in May. I mean, this is crisis mode. It might have even been Rich who said before, we can't undo all of the good that we've done helping end addiction with this, with the opioid crisis. We need to get back on the ball and really try to control this whole prescription and illicit drug abuse crisis. So there's this program from the federal government. It's called the ODMAP, the Overdose Detection Mapping Application Program, and it collects data from a number of sources, and it's telling us clearly that we're getting back into the red zone. And we know, as I mentioned before, stressful times, whether it's literal stress, financial stress, we know that it increases mental health disorders, it increases drug abuse, it increases overdose, and even increases things like suicide. Okay, just so that I could set everybody on the same page, I've probably seen tens of thousands of pain patients in the last 20 or 25 years. And not every patient that's prescribed a controlled substance does poorly or develops some substance use disorder. Many patients do really well, and their quality of life gets better, and life overall gets better. So when you look at the total chronic pain population, some people will take their medicines a bit early or not follow the instructions, but it's really the minority of patients that go on to abuse their prescription drugs or develop an outright opioid use disorder altogether. So what's your clinician to do? We have these guidelines. Who's ever clicking the slides, thank you. We have these guidelines that were given to us a few years ago, and some doctors didn't like the actual content, but the overall theme was just, it changed the paradigm. It changed the way that doctors treat pain. It gave us a roadmap on what does responsible prescribing look like. And it gave us a checklist of things to do and not do, a literal checklist, even though I don't show it here. Your doctor can go to the web and download a 12-step checklist from the CDC about appropriate opioid prescribing. But one of the challenges is now, like Randy talked a fair amount about, that the insurers, Medicare, Medicaid, and all the commercial insurers are supporting telemedicine visits. And they did away with non-essential services like cholesterol checks and things. But I could tell you what I've seen on Main Street, that doctors have considered drug testing part of these essential services. And when you look at the data from most of the labs, drug testing has kind of fallen off a cliff. I'll tell you, as a practicing clinician, the only way to know what a patient has taken is to do drug testing. We have prescription drug monitoring programs to see what the pharmacy has dispensed, but there's no other objective tool that I know of to tell what a patient has taken other than drug testing. And I'll tell you now, we've seen the data kind of fall off the cliff. So I think we need to reorient our prescribers out there to what safe practices look like when it comes to opioids and controlled substances. If your patient is doing well, if they have good pain relief, if the family member says, hey, mom's back to doing some gardening, or we got her to go to church again, if there's improvement in functioning and an acceptable side effect profile, to me, that's a rational patient to continue medication management on. But if there's no pain reduction, if their function goes down, if the side effects are just unacceptable, and I mean any side effects, constipation, nausea, sedation, then you need to have an exit strategy prepared. But it doesn't mean you're abandoning your patient. It just means that opioid or controlled substance therapy might not be the best therapy for your patient. One thing I want to be crystal clear on, there are a number of societies that have said, listen, during the COVID pandemic, this is not the time to rapidly wean your patients off their pain medicines. We're not going to trade one crisis for another. Listen, some people call the chronic pain crisis an epidemic as well. So you need to figure out how are we going to more closely monitor our patients. And I think Randy talked a little bit about telemedicine. I'll make some comments about it as well. It is vital that we keep our finger on our patient's pulse about how they're doing. And we don't just monitor their physical function. We need to monitor their mental function as well. We always have to make sure they have enough medication to avoid going into withdrawal, because that would be bad for our patients. And now's as good a time as ever to educate our patients about the opioid antidote, the reversal agent called naloxone. Remember, the AMA has put out some guidance to clinicians out there, and Randy mentioned this a little bit. There are special privileges given to those patients who need substance use disorder treatment, buprenorphine, methadone, naltrexone. They've been designated as essential services, and if your patients or family members need these services, they can continue to get them even via telemedicine. I could prescribe a medication to a patient that I've never seen face-to-face because of the emergency rules that have been set into place. A couple things for the clinicians that are on the line right now. We need to become a little bit of psychologists in these stressful times and discuss with our patients how they cope stress. One of the most important things I do is I stress to patients, listen, do not take your pain pills as a sleeping pill, as a muscle relaxant, as a feel-good or a chill-out pill. These are very specific medicines with a very specific purpose. And I tell them in no uncertain terms during this crisis, they are not allowed to drink. That's correct. No alcohol while they consume controlled substances, and certainly avoid illicit drugs. Almost all of the labs now have home testing measures or patient service centers that you could send your patients to. So don't forget about the need to objectively assess what your patients are taking, and then talk to them in general about staying healthy, sleep and nutrition and exercise and meditation and those kind of things. All right. For my final slide, I'll talk a little bit about the way healthcare has changed, especially for those of us that do pain management. You know, for those of us who've been seeing patients for decades already in person, this has been a dramatic shift, having to see people electronically or virtually. And for some patients, it works really well. For other patients, they're not so communicative over this new brand of telemedicine. So we have to remember that we need to individualize the treatment for patients, for every single patient. Every patient is at risk for misusing their prescription drugs, alcohol or illicit drugs, but especially those with mental health or substance use disorders. We need to stress to our clinicians that they have to develop a new skill set in monitoring for prescription drugs if they're prescribing these agents. Even if they don't want to, they have to, because it could be life-saving. Again, clinicians need to monitor not only the patient's physical condition, but their mental status as well. And I think, as Randy mentioned before, there are a number of resources available to help the general public and the physician community alike, with the goal of helping to reverse this trend of going back to an opioid crisis and getting back on the right foot. It seems like we've taken our foot off the gas a little bit when it comes to trying to protect our society, and we really need to get our clinicians back on board with strict monitoring of patients who are prescribed controlled substances. I'll stop there and turn it back over for an introduction for Samantha.
Thanks, Dr. Gooden. Next up is Samantha Holcomb, who's the Senior Director for Practice Improvement and Consulting at the National Council for Behavioral Health. As Senior Director, Practice Improvement at the National Council, she oversees a portfolio of healthcare delivery and financing programs to drive clinical change and improve health outcomes for behavioral health populations. In this role, she has designed and delivered technical assistance and coaching for behavioral health providers in the areas of population health management, value-based care, and alternative payment models, care pathways, and care coordination, quality improvement, and data-driven decision-making. Sam holds a master's in public health from the Johns Hopkins University Bloomberg School of Public Health and a Bachelor of Arts in Psychology from the University of Maryland, College Park. Sam, we look forward to hearing from you now.
Thank you so much. So I'm going to talk today about the experiences that behavioral health providers and those they serve, such as people receiving treatment for substance use or opioid use disorders, in transitioning and leveraging technology in response to COVID-19. But before I get started, for those of you joining today who are unfamiliar with the National Council, we're an association who represents over 3,300 community behavioral health, which is mental health and substance use, provider organizations across the country. So as we've said, the COVID-19 pandemic has resulted in rapid policy changes across the health system. I'm not going to go through all of these in detail as they highlight many of the changes that Mr. Pate already covered, but this slide contains a general summary of the many provisions put in place during the public health emergency, most notably the expansion of telehealth services, states' ability to leverage Medicaid 1135 waivers, and policy changes to facilitate continued access to substance use disorder treatment, particularly opioid use disorder. So providers across the country really rapidly mobilized to transition services to telehealth where appropriate to maintain access and safety for clients. I'm going to talk about what that experience has really looked like for behavioral health providers, and just want to note that I will be talking more generally about behavioral health experiences, including both mental health and substance use providers today. I know this webinar is primarily focused on opioid use disorders, but I think it's so important to note that many with substance use conditions also experience mental health needs, especially in a global pandemic like this. But just to give you a sense of how drastic this transition has been, the National Council conducted a survey of over 1,000 community behavioral health providers, and what it saw was that prior to the public health emergency, many of our providers delivered less than 20% of care virtually. Since the pandemic, a majority, so over 90% of them, say they now deliver over 60% of their care virtually, many delivering as much as 80% virtually, and many also anticipating that a higher level of service will continue to remain virtual even after the public health emergency ends. This rapid transition has really included expansion of a variety of programs and services being delivered via telehealth. So for many, I think we think of individual therapy coming to mind when we think of telehealth. However, many of our providers have also transitioned group therapy, transitioned medication-assisted treatment, medication management, and even in some cases more intensive programs such as intensive outpatient or partial hospitalization programs. That being said, this transition did not come without its challenges, and we've been working alongside our members over the past few months, and as we've done so, some key themes have really emerged in terms of what barriers they've tackled. First and foremost, just being procuring equipment, right? Many providers needed to invest in purchasing of equipment for staff because they weren't traditionally delivering these services, especially with staff all remote, at a time when revenue was declining and demand for technical equipment was outpacing supply. In addition, it's important to note that many staff had not previously delivered telehealth services. And for those of you who are experienced or have familiarity with telehealth, it does require a very different skill set. And if you break it down even further, you think about delivery via audio, video versus telephonic even requires different skill sets and different ways of engaging with clients. So many providers were challenged to rapidly train up staff in these skill sets. And I will say, although staff have adapted quickly, there is still continued need here. The community largely did come together to provide solutions or support through grant funding and training opportunities and associations stepping in to connect providers. And we have seen that many of those who already had telehealth in place or had more robust infrastructure were really able to transition more quickly, and were happy to lend a helping hand to others who are getting on board. Another challenge we saw was patient access to technology, which I don't think is a surprise for anyone. Clients who live in rural areas particularly do not have good connectivity, especially for audio-video connections. In addition, many providers serve populations with limited income or people who do not always have phones or internet access reliably, and taking into account those that we're working with, large proportions of clients experiencing homelessness. And then when there is access, I think there's also challenges with patient wariness of technology. So clients with serious mental illness or paranoia may be wary of telehealth services. Some clients, such as older populations, have discomfort with using technology. And in addition, clients who find comfort and proximity to their groups can really struggle with this transition, further exacerbating their feelings of isolation or loneliness. We've seen a lot of innovative approaches across the board. We've had providers who have been offering, quote, drive-in services or the like, where clients can come and connect to Wi-Fi on their phones or obtain an iPad to receive services while sitting in the parking lot of a clinic. We've seen providers deploying Wi-Fi hotspots in areas where they have high client populations. And as things begin to open across the country, many providers starting to find safe locations to provide in-person, socially distanced support groups. We've also seen a change in perception over time as it comes with use of technology. So many providers are gathering customer feedback, and in many places we're seeing this change over time of clients seeking to continue virtual care after the public health emergency ends, or feeling as though they have the same level of access or support to their therapists or other staff than they had before, and in some cases feeling as though they even have more access. And then there's the business aspect of all of this. So I'd be remiss if, I didn't call out the fact that policy changes don't always necessarily translate into reimbursement change in real time. And many providers that we work with saw a significant drop in revenue, even when they were able to transition quickly to telehealth. And some analysis is starting to show that revenue is starting to right size with the scaling of telehealth, but sustainability really requires continued parity in pay. And finally, that gets us to where we go from here. And below are some of the many considerations that I think we all have to take into account in the future. First and foremost being increased need. We already heard this from Dr. Gooden, and other experts across the board have already forecast significant increases in mental health and substance use conditions on top of the opioid epidemic that continues and seems to be worsening with a public health emergency. Issues with access and workforce shortages predate the public health emergency within behavioral health and can be exacerbated by the projected financial shortfalls across the states. So one of the key questions I think we all need to ask ourselves is how can we leverage technology to really address some of these needs and increase capacity to meet anticipated needs. Health equity, although telehealth removes some barriers we see in access, such as transportation or childcare during services, there's still significant challenges, like I said earlier, for those who don't have the means and access to technologies and reliable internet, as well as the fact that safety and privacy come into play here, right? There is a huge risk that those in an unsafe environment will not be able to engage in supportive treatment in those environments. Parity is critical, so behavioral health providers have been battling for parity to right-size chronic underfunding and low reimbursement rates forever. And although parity has been at the center of conversations during telehealth expansion, we need to ensure and maintain parity for those services. Quality of care, so although there is evidence-based for telehealth services, we've transitioned many programs that have not traditionally been delivered virtually, and in some cases use new digital technologies. So as we settle into this new normal, now is really the time to evaluate and assess which programs and services maintain quality and which might need redesign to ensure quality of care and real outcomes for the clients they're serving. And we also need to consider what additional training or support staff need to deliver these services effectively. And then in addition, when it comes to population health management, we really need to understand if there are populations, conditions, or risk factors that influence the effectiveness of virtual services. What's the right mix for the client? Leveraging digital technologies. So from the provider perspective, I'm talking a lot about telehealth because that's how many of our providers have transitioned their service delivery. However, we're increasingly seeing digital therapeutics or applications coming to market, and the question really becomes, how can both consumers and providers leverage these to their benefit? And then finally, mixed delivery methods. So as we watch reopening happen across the country, providers are really starting to ask about mixed delivery methods for treatment. For more complex programs, are there elements that remain virtual while others return on site safely? And for groups, a lot of what we've heard is, what if some clients want to return while others would prefer to remain at home? Do we maintain the group and the cohesion and have mixed delivery, or separate that so participants are either fully or virtual or fully in person? And so those are just some of the questions that I encourage all of us to continue looking at, analyzing as we continue down this road. I know a lot of us have said, you know, the cat's out of the bag, there's no bringing it back. So now it's, how do we make sure that everything we've let out really meets the needs of all of the consumers that we have across the country? And I will stop there.
Thanks so much. Appreciate it, Sam. And finally, we're pleased to be joined by Tanya Malik, who is a national leader in telehealth and telemedicine, having focused in this sector for nearly 3 decades, a lawyer and entrepreneur. Tanya has concentrated on telemedicine solutions and started healthcare companies to facilitate online patient-provider interactions for primary care, mental health treatment, and naturopathic and integrated medicine. In 2007, she started Cope Today, Telemental Health Company, which was acquired by MindCare Solutions Group. She's the immediate past chair, the Telemental Health Special Interest Group for the American Telemedicine Association, graduate of the University of North Carolina, Chapel Hill, and Georgia State University. So with that, pleased to turn the call over to Ms. Malik.
Hi, thank you, Rich, and thank you, everyone, for having me. Where we want to start, and I think it's a perfect build from Jeff and Sam's presentation, is our CEO, Ann Johnson, when she came on board, we were the American Telemedicine Association, and she said everything's right with our name except the first 2 words, because telehealth is global and telehealth is health. So that is where, until we rebranded ourselves to be ATA, because that's the way we believe telehealth is health. And we're going to do just some basic definitions now, because we're going to do a quick summary of what it was like pre-COVID and what it's like now. I'm not going to repeat what other people said, but really what that means going forward, what that has meant, certainly in the substance abuse area. So on screen are some very basic definitions that matter. Originating site, where the patient is, distant sites, where the clinician is. And where telehealth is going a lot is asynchronous, so not at the same time, especially in mental health. You could have someone talk to their therapist, I'm saying this in air quotes, and video it, and then later a psychiatrist or a mental health counselor see it and then respond back. So asynchronous. Synchronous, of course, is at the same time, and you've heard of hub and spoke or store and forward, which is basically like asynchronous. One thing I want to highlight is that the ATA and in this public health emergency has made on our website all of our best practices available to everyone. So there are best practices in video conferencing for telemental health that we've done. We have reviewed them. They've been updated in conjunction with the APA, and we've reviewed them all and made sure that they still are applicable in this emergency. So that is something for you. What we used to talk about was out of 1834M of the Social Security Act, and these were the requirements for telehealth, and they, of course, were more restrictive. You were allowed to get reimbursed from Medicare in a rural area, and all of those places on the screen is where the patient had to sit, but home was not one of them. And then there were only certain types of providers that could get reimbursed. So then, as you all know, everything changed, and the 1135 waivers that Randy talked about, and then the CARES Act and the other acts that went through Congress changed it all. But the significant ones is that the patient's home is now the originating site. So here are the questions for us in the telehealth community. There are several bills that I'll talk about in just a second that are going through Congress, because I like this because, you know, you'll say to your children, maybe, that'll take an act of Congress before you get my car. It actually is an act of Congress that has to change these rules now on a permanent basis. Because when you start thinking about it from a clinician point of view or administrator point of view or anything, once the public health emergency is over, it's like Cinderella's ball is over, and there you are in the pumpkin, right? What do you do? What kind of leeway are they going to give? Time frame? What's going to happen? Are all these rules just going to go back to exactly the way it is? So there are people on the Hill, and I'll talk to you about that, who are trying to make these changes permanent, and certainly the ATA is. So 49 states, and I don't know y'all well enough to talk about the one state that did not waive license restrictions, but there's one out there that didn't. And then what's really important for SUD and OUD is that the Ryan Haight Act was suspended as far as what Jeff talked about, being able to prescribe without an in-person exam for controlled substances or narcotics. So, and then you'll see the other things of more coverage, HIPAA. You have to have a good faith effort for the enforcement, and that opened up a whole lot of other ways that people could connect, Zoom and Skype and FaceTime, where you would not be, the Office of Civil Enforcement would not come down on you as hard as long as you had a good faith effort. But there's more to talk. There would be a lot more, a whole webinar just on that. So what happened in the public health emergency is you can now, as Jeff has talked about, prescribe controlled substances without an in-person. But this has been a big issue for us, a big issue for ATA, especially the telemental health SIG. We have worked with the DEA. We have put forth letter after letter to Congress and caucuses, telehealth caucuses, and all kinds of bodies who are interested in this to try and get the DEA to move to make that permanent, where there's a special registration provision in there, and we outlined how it could work. So here is some guidance on the screen from the DEA about how to move forward. And if you're a clinician, this would be worth looking at, and you may already have it pinned to your desk. But one thing I would tell you is that state law still applies. So you still, even when it comes to HIPAA, when it comes to anything that is out there that has been waived by the federal government, state law will still apply. Medicaid rules are there, and then you can look at what the commercial payers are doing too. Of course, Medicare usually leads the way. So will these changes stay? Oops, I'm pushing it, sorry. Someone else is too. So 30 senators have already asked to make the changes permanent. And what I have on the screen here is what I thought was really interesting, are some of the people, the lead sponsors on these bills. These people generally, you would not put them together at a tea party, but here they are, from Lindsey Graham to Amy Klobuchar, and you can see the people who are listed there, who are working together to try and make these changes permanent. Another really interesting stat is the number of Medicare beneficiaries using telehealth services during the pandemic increased 11,718% in just a month. So, and some states have already made the changes permanent. Massachusetts, who's always been a leader in healthcare, Colorado, Idaho, and then a really good source for you is the Federation of State Medical Boards. They have a list, and it was up to date as of July 17th about what's going on in the state. But I do want to remind you that Ryan Haight is a federal law. So whatever, that has to change on a federal basis for that to erase some of the unintended consequences of Ryan Haight. So the other thing I want to let you know is that there is a task force on telehealth that was inviting public input as it's over now, July 13th, but it is a conglomeration from the NCQA, ATA, and the Alliance for Connected Health. And it is they want to know from the public what's happening, what has worked, what hasn't, and the areas that they're focusing on as we work to hashtag cement the gains is the effect on telehealth and its cost of care, because the barriers used to be to complete reimbursement. It's people would say that, oh, it's overutilization, and so we can't reimburse everything. Well, I just told you the utilization number, but we need to really unpack that and see where we can move forward permanently. Patient safety, Sam mentioned that, and program integrity, data flow, and quality measurement, and other policy. That's where that task force is focusing on. And I just tried not to take a breath because we have 4 minutes left and there may be questions, but I will stop right there so that we could get any questions in. Matt, I'll send it back to you.
Thanks so much. Appreciate everyone's presentations, and you have a couple minutes left. So before we turn it back over to Mary Bono to close things out, just want to get a quick question into each of this panel's speakers, and with the time constraints, if you could make your responses as short as you can. Dr. Gooden, question is, are there current data trends or peer-reviewed literature related to the impact of COVID-19 and the opioid epidemic that are particularly alarming? Are you seeing these trends play out in your diagnostic-based work?
Yeah, it's a great question. I alluded early on that I was going to talk about some of the data from Quest Diagnostics, and I didn't have much time to, but I will tell you that we mined the data. What did aberrant drug tests look like pre-COVID and then post-COVID? So March, April, May, mid-March to, next couple of months. And we have seen a clear spike in fentanyl positivity. As you all know, fentanyl is an analgesic drug, but most of the illicit drug use is synthetic, illegal fentanyl. So I'd have to say the number one thing I'm worried about, and we know it contributes to overdose deaths, is that once people go to the streets to procure their illicit drugs, I think that's the major source of opioid-related deaths these days. So really, again, a reason that we need to monitor our patients very carefully.
Yeah, absolutely. Thanks. Appreciate that. And for Sam, we've heard from Randy Pate earlier about some of the steps they're taking to better accommodate digital health technologies during this pandemic. From your perspective, are there other areas of legislative or regulatory policy that you'd like to see addressed now or continued once the current circumstances change?
So I think on a similar vein, first and foremost, it's really critical to continue these allowances for the foreseeable future to ensure maintained access during the pandemic and also beyond. And I think secondly, really studying the clinical and financial efficacy for telehealth before making permanent any of these changes. So we've recently signed on to a support letter for HR 7078 that requires telehealth utilization data collection within Medicare and Medicaid and provides grants to states to collect similar data at the state Medicaid agencies. So really thinking about how we know and understand what the most effective and informative delivery mechanisms are.
Thanks. And last question for Tanya. We've certainly seen a precipitous rise in the use of telemedicine, which makes a lot of sense continuing or considering the circumstances. And given what we've seen since March and the utilization of telehealth, is it too late to put the genie back in the bottle? Do you think we'll be able to leverage the infrastructure that's now being developed for COVID-19 to a more sustained practice option?
Absolutely, and we're hearing those exact words from the top of major health systems, from CMS, that the genie is out of the bottle. It's here to stay. The barriers to telehealth for provider and patient adoption, reimbursement, and technology, and in very short time, we have eliminated all of those barriers, and those have been barriers that the telehealth community have been working to eliminate for the last 20 plus years, which were eliminated just as soon as COVID-19 hit. But we were ready, and we are ready as we move forward to cement the gains.
Yeah, it's definitely a new era, a lot of change, and I think we'll definitely see a lot of this sustained. So just want to thank everybody and turn it back over to Mary Bono to close things out.
Thank you, Rich. Thank you for your excellent moderating, and also to our speakers and panelists today. Thank you very much. I want to thank all of you for joining us for this afternoon's webinar around the role of digital health and telemedicine. We hope you found the dialogue engaging and impactful as we consider the implications of the current COVID-19 pandemic and how we look to address the treatment of acute and chronic pain along with those who struggle with SUDs. So upon completion of today's webinar, a recording will be made available to all registrants, and then it will be posted to both the CPOP and the MAPTA websites. So if you have not yet done so, we encourage everyone to register for the remaining 3 webinars within the series. Next Monday, July 27th, we'll hear from an impressive panel around implications of the COVID-19 pandemic on access to MAT. We'll hear on that webinar from Congressman Paul Tonko, who sits on the House Committee on Energy and Commerce, as well as Ms. Claire Brennan, Section Chief of the DEA's Diversion Control Division, along with her policy section colleague, Anastasia Martin. So should there be any questions or follow-up to this webinar, please contact Matthew Rubin. Once again, thank you for joining us today, and we hope to be with you all again next Monday at 3:30. Thank you.